Hello students, myself Dr. Saramma Mathew, Associate Professor from the Department of Oral Medicine and Radiology, Vinayaga Mission Shankaracharya Dental College, is here to present you with the topic on Apthous stomatitis. Before starting the topic, I would like to all of you to know that few terms are there to be recognized in this topic. So first one will be the term of ulcer, followed by what is a vesicle, what is an apthe, what is denote the term of stomatitis, and how it can be occurring in the oral cavity. So to begin with, what is an ulcer? An ulcer is the break in continuity of the epithelium. When I say vesicle, what does it have to do with the Apthous stomatitis is that vesicles are fluid filled cavities which when later disrupts or erupts, it will lead to an ulcer. So that is why vesicles also can lead to ulcer in the oral cavity. So the term apthe, it is also known as canker sores, which is the topic related, that is why this topic is called as Apthous stomatitis. So the apthe term was initially coined or described by Hippocrates, who said that any ulcers which occurs in the oral cavity are called as aphthosis or apthe or canker sores. When these ulcers occurs in the oral cavity involving the entire mucosa, it is called as stomatitis, or in short, inflammation of the ulcers or inflammation in the oral cavity is called as stomatitis. Now the ulcers, it can be either an acute form or a chronic form based on the duration. Then based on its location and based on the types, whether or how many ulcers are there occurring in the oral cavity, it can be given as either a solitary ulcers or a multiple ulcers or a recurrent ulcers. The term recurrent means the ulcers which forms continuously or subsequently after an irritation and does give a lapse time and then again the ulcer forms. So there is continuous recurrence occurrence in the oral cavity. So that is why the term recurrence is used, and this recurrent is constantly used in Apthous ulcers. So hence it is also known as recurrent Apthous stomatitis. So what is the definition for recurrent Apthous stomatitis and what is the etiology related to it? So recurrent Apthous stomatitis, or in short known as RAS, is defined as the presence of recurring ulcers confined to the oral mucosa in patients with no other signs of any underlying disease. So the commonest etiology, it can be due to stress, which most often the studies have shown the stress is one of the major causes for occurrence of recurrent Apthous stomatitis. So another factor or the etiology which is frequently considered is the immunity. When the body's immune mechanism or immune defense system is lowered, the patients will automatically have several ulcers in their mouth. So that is why immunity also plays a role in forming of recurrent Apthous stomatitis. Then the other factors are like genetic factors associated with the commonest antigen called as human leukocyte antigen. And these genetic history means the patients will have a hereditary pattern where the ulcers will form in their mouth due to genetic perturbance. So the other underlying etiology could be systemically related, that is the gastrointestinal diseases. The diseases such as inflammatory bowel disease, Crohn's disease, or gastric ulcers can also cause moral ulcers. So the another etiology could be the hematological deficiencies, especially the vitamin B12, iron deficiency or folate deficiencies can also cause oral ulcers. The other etiological factor, again the systemic related, will be the hormonal factors. So all the systemic causes apart from the local factors or the stress or immunity can also lead to mouth ulcers. When coming to local factors such as the trauma and smoking,
parental authority is being rejected. Approval of peer group is extremely important at this stage.
Smoking, whereas the studies have shown that there is a negative correlation in formation of ulcers, because when a patient stops smoking, the nicotine content will stop the pro-inflammatory cytokines and the patient will also develop ulcers. So now moving to the types of oral ulcers or oral types of recurrent Apthous stomatitis, it is majorly types clinically seen is minor recurrent aphthous major recurrent
Development was put forward by Jean Piaget, whose world's
clinical types of an aphthous ulcer seen. So how do we classify this ulcers? Yes, it is basically classified into type A, type B and type C. So when type A, the ulcers last for only few days, which occurs only a few times in a year, are considered to be type A type of ulcers. Whereas in type B, there will be frequent and painful aphthous that last between 3 to 10 days. In type C, these ulcers are again going to be painful, and it is chronic course of ulcer, which one ulcer heals, there is no time gap, immediately another ulcer develops in the mouth. So based on the ulcer formation, it is classified into type A, type B and type C. So now how these ulcers are formed in the oral cavity? There are various factors which is involved in forming these ulcers. So major component in the ulcer to form is either it can be a genetic susceptibility or it can be due to the immunocompromised conditions. So in genetic susceptibility patients, how the ulcer is formed is through the human leukocyte antigen gene.
Accessing information in the brain. Assimilation is when the child is going to look at a dog in a park and think, oh, this dog also has 4 legs, 1 tail and a head, so this is cat. So that is when we come forward.
Cell mediated immunity, which will increase the macrophages, which will increase the pro-inflammatory cytokines such as interleukin 6, interleukin 1. So all these major and microscopically involved factors will lead to the development of ulcer in the oral cavity. So increase in pro-inflammatory cytokines will cause degeneration of the epithelium, will cause perivascular edema in that particular site of the basement membrane, and that stimulation of these cytokine cascades will lead to exaggerated cell mediated immune response, resulting in the localized ulceration of the mucosa. So this is what in microscopically when we see the cells involved for an ulcer to be formed in case of aphthous stomatitis. So the stages in development of an ulcer is particularly there are 3 stages. One is the pre-ulcerative stage, next is the ulcerative stage, and the third is the healing phase. So what happens in pre-ulcerative stage is the lymphocytic cell infiltrates in the epithelium, it forms the vacuolation. A particular localized vacuolation is initiated by the triggering factor, by the pro-inflammatory cytokines which is increased with the lymphocytic cell infiltrates, there will be vacuolation. So these vacuolation will degenerate the suprabasal epithelium cells along with the lymphocytic infiltrates. Here in this ulcer formation, there will not be any mast cells formation, but here only the macrophages and the lymphocytes are involved for forming an ulcer. So in the ulcerative stage, what happens is there will be increased infiltration of the tissues in the epithelium by mononuclear cells. So more extensive edema and the degeneration of the epithelium in the prickle cell layer of the epithelium will lead to formation of frank ulcerations with the fibrinous exudate formed as a covering membrane on the ulcer. So in the healing phase, what happens again, the body tries to reparative mechanism starts, and that is how the regeneration of the epithelium occurs, which in an oral cavity is around 21 days. So once the epithelium gets regenerated, the infiltration of the epithelium T lymphocytes, the keratinocytes will start developing, and that will mask the area of ulcer where it is formed. So clinically what happens in pre-ulcerative stage, how do we see is there will be a stage of erythematous margins in the particular site. Once the erythema is formed, after which the ulcers start developing in that particular area, and then the ulcers will have a well-defined margin, and the base of the ulcer will be shallow most often, and it will be covered by a fibrinous exudate. So this is how clinically an ulcer will look. So these ulcers in the healing phase, the top exudate will be covered by the regenerated epithelium, and the healing phase occurs. During the healing phase, there is no pain associated. Only in the ulcer formation stage, there will be patient will have pain. So this is a picturesque development of the ulcer. So initially, this first slide right side of the picture, you can see how the ulcer is formed. Initially, it is the normal epithelium where there is the basal cells, where there is the T cells and the fibroblast are there. Now, when the ulcer starts or initiation, there will be the erythema formation in the oral cavity. Once the erythema is formed, there will be primary damage response where there is initiation of the epithelium with degeneration of the suprabasal cells, and the pro-inflammatory cytokines will increase, and that will cause along with the associated bacterial content in the oral cavity will lead to degradation of the epithelial cells, and an ulcer will form. And the last stage or the last picture shows that there is the ulcers are healing with the regeneration of the epithelium. So, this is what clinically what happens for an ulcer is represented. So, moving to each type of ulcer, how it is going to be clinically presented. So, based on which we have 3 types I have mentioned before. So, that is the first one will be the major aphthous ulcer. So, what are the clinical features you see to diagnose it to be a major aphthous ulcer? So, it is also known as Sutton's disease, or it is also known as periadenitis mucosa necrotica recurrens. So, these are the other names for a major aphthous ulcer. So, here the duration will be from a period of 10 days to months. From the term itself, we can understand it is a major ulcer. Most likely it will be a solitary ulcer, and this will, when it heals, because it is greater than 1 centimeter in diameter, usually it will form a scar, and then the tissue destruction will be happening, so which leads to scar formation in the oral cavity. So, where it usually occurs in the soft palate and in the tonsillar areas, and it may extend to the oropharynx. So, usually it will be 1 to 10 single ulcers which persist for a long period, and there is no cyclic pattern, and there is a remission of intense ulceration. When the patient finds difficulty of eating, speaking and swallowing, then you have to rule it out to be a major aphthous ulcer. So, this is how the major aphthous ulcer looks clinically, wherein it is seen at the site of the ulcer is seen in the oropharynx, mostly in the soft palate region, and the ulcer's periphery is erythematous. The ulcer is a solitary one, and it is a shallow ulcer, but the size of the ulcer is greater than 1 centimeter in diameter. Moving to the next type, that is the minor aphthous ulcer. So, minor aphthous ulcer, how does it represent? It is also known as Miculis aphthei. So, most often this minor aphthous ulcer will be 1 to 5 in number. It is concentrated mostly in the anterior part of the mouth. So, usually in minor aphthous ulcer, there will be a prodromal stage.
All of them see. Classification. It's the ability to name and identify set of objects according to appearances, size or other characteristics. Decentering, where the child takes into
and it will be more painful. So, the duration is up to 10 days. But the differentiation here is, in the minor aphthous ulcer, there is no scar formation, and it heals reparatively with normal regenerative epithelium is there, because the size of the lesion is very less than 1 centimeter. So, there is no need for scar formation. So, that is how you diagnose from a major to minor aphthous ulcer. So, this picture will represent.
Place it in your mouth like this and take it out like this. Put it every evening after dinner before you go to.
And usually 2 to 5 in number will be seen, and these ulcer sizes is usually lesser than 1 centimeter in diameter. You can see the ulcer shape, it is more or less ovoid, surrounded by an erythematous periphery.
And humor. Modeling techniques and reward therapy is appropriate.
Aphthous stomatitis. So, this herpetiform, it is mostly confused with the hepatic virus aphthous ulcer. But here, how do you differentiate this herpetiform recurrent aphthous stomatitis from HSV affected ulcers? So, this ulcer of herpetiform aphthous stomatitis, these ulcers will be very small in size, which is around lesser than 1 to mm, and there will be multiple ulcers formed, and usually it affects the non-keratinized oral mucosa. Usually the aphthous stomatitis ulcer will be seen in the non-keratinized mucosa, whereas the herpetic ulcers will usually occur in the keratinized mucosa. So, that is a key point how we can easily diagnose between a herpetiform ulcer and an aphthous stomatitis. So, in this one, which is caused by an aphthei, The ulcers will be smaller, very less minute ulcers will be there, but they will be cropping up into multiple ulcers, which later during the healing phase will coalesce to form a single ulcer, and there will not be any scar formation. So, herpetiform ulcers and minor aphthous ulcer, there will not be any scar forming. So, clinically where do we see? Most often this herpetiform will be seen in the lateral margins of the tongue, in the floor of the mouth, and there will be a grey color without an erythematous border will be seen usually in the herpetiform ulcers. Of course, it resembles the herpes simplex virus infection, but here the aphthous will be very painful and it will be usually affected in the keratinized, non-keratinized mucosas. And they form a confluent ulcer to form a coiling. Sometimes there will be with scar formation. So, this is how clinically the herpetiform ulcers look. You can see multiple ulcers, the erythematous border is not well delineated around the ulcers. There is 2-3 ulcers. Sometimes these ulcers will be erupting as a vesicle. So, in the vesicles might rupture and form a herpetiform ulcer. So, this is the ulcers site, where most often it is seen in the soft palate sometimes, or in the buccal mucosa where there will be multiple crops of ulcers. So, usually these ulcers are not formed as a frank ulcer. From the vesicle it might erupt as an ulcer. So, how do we differentiate or consider these ulcers are? It can be either viral stomatitis, then there is these aphthous stomatitis, the such type of ulcers will be seen in viral stomatitis, cyclic neutropenia, pemphigus, erythema multiforme, drug induced ulcerations in HIV patients, and inflammatory bowel disease. So, these are the areas where these aphthous stomatitis will be more commonly seen, and how do we differentiate it from it is the key factor, knowing these aphthous stomatitis. In case of cyclic neutropenia, these ulcers will be remnant, will be seen for 21 days, after which it will subside. So, that period of 21 days will tell us if the patient, and with the underlying hematological investigation, we will know whether the patient is having cyclic neutropenia related ulcer or it is aphthous stomatitis. So, viral stomatitis, how do we differentiate? I have already discussed before. Then moving to the next differential, that is the pemphigus and pemphigoid. Usually it will occur in a wider area and the patient will have skin lesions, and usually this pemphigus and pemphigoid, the blisters will be erupted in the mouth, and after which an ulcer will form or a vesicle can lead to an ulcer. Similar way in erythema multiforme, with the history we can able to diagnose whether the patient is having aphthe or erythema related ulcers. So, similarly in HIV and inflammatory bowel disease, these patients are more prone for aphthous stomatitis. So, HIV patients, from the blood report we can identify which is causative factor for the formation of aphthous stomatitis. To summarize all these ulcers, I put it in a chart form. So, what all things you will be considered for an aphthous stomatitis, or which form of aphthous stomatitis is. It can be divided into minor, major and herpetiform. What are the factors which we will look upon for to diagnose from the other ulcers are: first is the peak age of onset should be considered. In minor aphthous ulcer, usually the age will be in the second decade. For the major it will be first and second decades, and herpetiform it is usually in the third decade. And the number of ulcers formed for minor will be 1 to 5. For major, usually it is a solitary ulcer. To the maximum of 3 ulcers can be formed. Herpetiform, it can arise from 5 to 100, sometimes 100 crops of vesicles can rupture and form an ulcer. The size of the ulcers in millimeter, for minor it is always lesser than 10 millimeter, for major it is greater than 10, and for herpetiform it is 1 to 2 millimeter. The duration is, minor will subside within 7 to 14 days, whereas the major it will take from 2 weeks to 3 months, and for herpetiform it is always the 7 to 14 days. So, this heals with scarring is minor, there is no scar formation in the oral cavity, whereas for major there is always a scar formation is seen, and herpetiform there will not be major type with no scarring will be formed, but however if the ulcers are around 100 and if it is coalesced to form an ulcer, if it is coalesced to form a big ulcer, then there is a chance of scar formation. So, where is the site most often seen is for a minor aphthous, it is always the non-keratinized mucosa. Major ulcers can occur in keratinized and non-keratinized, that depends upon the underlying etiology, and herpetiform, it is always a non-keratinized mucosa. So, considering that, the Apthous stomatitis usually occurs in non-keratinized mucosas, especially in the labial and buccal mucosa, the dorsum and lateral border of the tongue. So, what is the syndromes associated with this Apthous stomatitis? Is the commonest syndrome is the Behçet's disease. So, Behçet's disease, it's a multi-organ system involving disease which has the potential to form an Apthous ulcers in the mouth. So, in this condition of patients who have diagnosed with Behçet's disease, they always have a recurrent oral Apthous ulcers, they will always have recurrent genital ulcers and the eye involvement. So, this is the triad for a condition to be diagnosed as Behçet's. So, the patient will have recurrent oral Apthous ulcers plus genital ulcers recurrent and eye involvement. Only in these three triad is involved, then we consider it to be called as a Behçet's disease. So, other manifestations apart from these three manifestations are the patients might have joint ulcers, skin lesions, it might also affect the central nervous system, vascular also gets affected, and the intestinal lesions. So, involving all this are there, then we call it as a syndrome associated to recurrent Apthous stomatitis. So, how do we manage such type of patients clinically? So, there are various modalities where you can treat a patient. First and foremost, we always go for topical application followed by systemic therapy. So, in topical applications, the gargling or oral rinse can be the ideal method to heal as a treatment for an ulcer. So, considering the oral gargle, either the mouthwash can be an antiseptic mouthwash or an analgesic or an antibiotic mouthwash can also be given for the lesions. So, when once the patient is diagnosed, whether it is major or minor, according or herpetiform, the treatment modality also varies, and depending upon the chronicity, depending upon the painful nature of the lesion, the treatment modality varies for each type of Apthous stomatitis. So, in an antiseptic mouthwash, the foremost mouthwash which we consider is the chlorhexidine gluconate mouthwash, which can be swished and rinsed twice daily, and it will subside and the ulcers will subside on its own. In an analgesic way, where the patient is having more pain, the topical application what can be given is the benzodiazepine mouthwash along with lignocaine, that is the local anesthetic can be mixed, and that can be given as a topical application for pain reduction. So, if the condition is still persist, if the ulcer is not healed again and there is severe pain, then we have to go for other steroids application in the topical mode. So, one such commonest topical corticosteroid which we give is the triamcinolone acetonide, which is also available as an ORA base, where there will be an adhesive component so that the triamcinolone can retain in that ulcer for a longer time. So, it is commercially available as an ORA base. So, this triamcinolone paste can be applied 4 times a day in the patient's ulcer and then can be rinsed, and that will help for healing phase. Along with this triamcinolone, there is other topical corticosteroids such as budesonide or beclometazones can also be given for these type of ulcers. In case of major ulcers, these topical applications can be kept in that by a adhesive paste, and that will be on a gauze and applied continuously for 4 times a day, and that can be allowed for healing. So, the other, along with the corticosteroid topical applications, we can also give topical antibiotic mouthwashes, because as mouth contains lots of overload of bacterial contaminations. So, to avoid that, we can also give prescribe topical antibiotic mouthwash along with these corticosteroids. So, once the condition is still controllable or manageable, if it is, you can give topical application. If still the ulcers persist, then we have to give for systemic, or in case of major ulcers where there is a patient is having underlying some systemic conditions, and then the ulcer, major Apthous ulcer is not healing, then we can opt for systemic immunomodulators like cyclosporin or thalidomide or azathioprine. These are all pellets or capsule form we can prescribe. So, other recent therapies which is involved is the giving the immunomodulators like interferon alpha vial injections or pentoxifilin injections can be given. So then other therapies also involves the nicotine replacement therapies, where nicotine will reduce the pro-inflammatory mediators and thereby the ulcer formation can be reduced. Also in case of gastrointestinal ulcer or patient is having gastritis, with the help of sucralfate, which is a metabolite which will coat these ulcers in the stomach, and the same sucralfate can be prescribed for oral ulcers also. These are all systemic mode of drugs. The recent ones, the ulcers can also be healed using therapeutically using a low energy lasers, which will also help the healing phase without scar formation. So these systemic modulators are all, or systemic drugs are given in case if the ulcer is persistent for a longer time and in case of a major aphthous ulcer. So this is how we manage the patient of aphthous stomatitis. So I hope that with these pictures you will be able to understand or diagnose now which type of ulcers. So the picture on the left, I guess the site of the lesion is in the soft palate region, and it is a solitary ulcer which is surrounded by an erythematous border. So this could be a case of major aphthous ulcer. On the picture on the right side, I hope you can diagnose that, because where the site of the location of the ulcer is at the lateral border and beneath the tongue, and it can be due to either trauma, irritation, and then this ulcer could be a minor aphthous ulcer. So with this, I hope you have understood the topic of aphthous stomatitis. I hope you have understood the topic clearly, and thank you for patient listening.